Hi, my name is Kaylin. I'm a biokineticist at the University of Johannesburg, and in this video we are going to show the knee special tests. So the first test that's going to be shown is called Lachman's. It's basically to test for ACL involvement or anterior translation of the tibia. So we want to get the knee in like 20 to 40 degrees flexion. We then want to grab underneath and with the other hand almost just stabilize the femur. And what we want to see is any laxity or anterior translation of the tibia. So we stabilize with this hand and we push up with this hand. A positive test would indicate some laxity or almost like a soft, mushy feel, usually with no end feel. So the laxity will be pretty intense. The next test we'll be doing is called the anterior draw test, also to test for anterior cruciate ligament pathology. So what we want is the knee to be in 45 to 60 degrees flexion. We want to stabilize the foot, so we can sit on the foot like this. Our index fingers are going to be in the popliteal fossa and our thumbs on either side of the patellar tendon. Again, we want to just position our hands like that and almost pull forward so that we get that anterior translation of the tibia. So positive would indicate any laxity, so you would actually see it through the skin moving, or any pain from the patient experiencing an anterior cruciate ligament pathology. So in the same position, we are doing a posterior draw test. This is to indicate if there's any pathology with the posterior cruciate ligament. The same position of the knee, also just stabilizing that foot. The fingers are in the same position, and all we're doing is pushing backwards. So we're trying to get a posterior translation of the tibia. So what we want to see is a posterior translation of the tibia on the femur. So we'll almost again see that laxity or movement, and it'll be pretty predominant. And also any pain while doing that movement. So this next test is to test for medial collateral ligament laxity. So what we do is we just want to get the knee into slight flexion and we just want to stabilize the ankle with the other hand. Then we're lifting the knee and we're just applying a varus force from the outside in, checking for any laxity in the medial side of the knee, which would indicate some pathology with the MCL. The next test is also for a collateral ligament, the lateral collateral ligament. So what we're going to do is the same position, 20 or 30 degrees flexion of the knee, stabilize the ankle, and we're just applying a varus force to the inside. So we're looking for the laxity on the outside to see if there's any laxity or any discomfort or any pain with this movement. The next test is called McMurray's. McMurray's is to test for any meniscal pathology within the knees. So what we do is we flex the knee, right? We internally rotate the tibia. And while we're internally rotating the tibia, we are going into extension and we are applying a valgus force to the inside. So you want to kind of do this a few times just to reproduce that pain. Flexion, internal rotation of the tibia, and a valgus force. For the medial meniscus. The next test is also for meniscus. This is for the lateral meniscus. We're doing the same thing as the medial, McMurray's. Flexion of the hip, external rotation of the tibia, and a varus force. You want to repeat it a few times to see if there's any laxity or discomfort. With meniscal injuries, most of the time the patients won't have pain, but they will have severe laxity and discomfort, and almost like the knee's going to give. The next test to test for posterior cruciate ligament is we're basically going to flex both of the knees up to 90. We're then going to put our arm so that the patient can lean his leg on the arm. And what we're looking for is basically a sag in the tibia. So a posterior translation of the tibia on the femur, and we're looking for like a gap. So the next test we'll be doing is called the Clark sign. So basically what we're doing is we're using our thumb and our index finger, basically this part of your hand here, and we just want to get the superior aspect of the patella and just push down on it. So we want to get the superior aspect of the patella, we want to basically push down and in. And while we're doing this, we're going to ask the patient to contract his quad. What we're looking for here is basically apprehension in the patient's face, or not wanting to contract the quad because there's too much pain. You will also feel, if the test is positive, you will feel crepitus and patient not wanting to contract their quad. So let's start the Clark sign. Superior aspects of the patella, we're just applying a downward forward force, and then we ask the patient to contract their quad. This test is positive if there is pain underneath the patella or any cracking sound, or the patient explains that it's very uncomfortable and painful. It would probably be positive for chondromalacia. The next test we're going to be doing is Noble's, and this is for tightness or pain in the insertion of the iliotibial band. So we're flexing, basically flexing the hip. We're then going to palpate where the ITB inserts. So the ITB should insert on the tibia tuberosity. So the ITB goes over and inserts into the tibial tuberosity. So we're palpating that, and while we're in flexion, we are pushing into that insertion. We're pushing into the insertion and we're extending. If the patient complains of pain or the reproduction of pain that they felt, then it is positive for tightness of the ITB in the lateral aspect of the knee. So the next test we'll be doing is called reverse Lachman's. This is to test for any involvement with the posterior cruciate ligament. So the same thing with the anterior, you're just looking for that lag. So we're going to hold the tibia. We're basically going to stabilize with the right hand on the femur, and we just almost want to translate the tibia posteriorly. So we want to push the tibia posteriorly to see if there's any sag there or any movement, any laxity. So the next test I'll be doing is an Apley's distraction and compression test, basically to confirm or deny if there is any meniscal pathology. So what we want to do is flex the knee at 90. We want to externally rotate, and we want to compress the tibia. If there is pain, it's positive for medial meniscus pathology. While the knee is still in flexion, we want to internally rotate and again apply the same compression. If the pain is reproduced, it's positive for lateral meniscal pathology. With the knee still being in flexion, we want to do the same thing, almost externally rotate, but now we're distracting. So we're pulling up. So we're distracting the tibia. If there is relief of pain during this motion, it almost confirms that there is meniscal pathology of the medial meniscus. We then internally rotate again, stabilize the femur, and again distract. This should relieve the pain on the lateral side of the knee, which involves the lateral meniscus. The last special test for the knee is called the patellar apprehension test. So we're basically just palpating the patella and also just pushing laterally, medially, inferiorly, and superiorly, just to see for any movement, excessive movement of the patella, and any pain from the patient's face to say if it's uncomfortable. A positive test would obviously be excessive movement of the patella, laterally and medially, as well as superiorly and inferiorly. And this would just be positive for patellar subluxation. So that concludes the special tests for the knee.